Okay, so it's 2 o'clock and I welcome you all to the 5th Live IJCTO Summit. Thank you all for making for this program. Like all good things should start on time, so we will start it on time. It's 2 o'clock. The content of this program, the Fellows course, has been divided into 4 sessions. The first session is the beginner's corner. So it is meant for people who want to start a CTO program. So what type of hardware, what is to be kept in the cath lab, what is expected out of your cath lab personnel. So that is basically the preparation of the team, preparation of your hardware, and a little bit know-how about the hardware. This will be followed by the basic course on anti-grade session, followed by troubleshooting session, and the last session will be on the retrograde basics. Now we have divided these 4 sessions, and I request that the question answers should be done at the end of each session. So that will at least help us to, you can jot the questions if you have, for each speaker you can jot it and keep it. So at the end of each session, we can take the question answers, because we have kept 15 minutes separately for question answers for each session. So I think after 2 sessions around 5 o'clock, we'll have a 15 minutes break. We can go out from that side to have coffee and cookies on that side behind, not on this side, because there is a parallel event happening in the grand ballroom. That whole place will belong to us from tomorrow. Today we have only this particular place and behind. Request you all to put your mobile phones on silent. This is a genuine request, because it can disturb the speaker, and it's not fair on us to disturb the speaker. So our genuine request is to either put off your phones or put it on silent mode. So we will keep reminding this, that the cell phone should be on silent mode. You have to keep on flashing it in between, that the cell phone has to be on silent mode. The lunch today was not a part of the program, so I made a last moment arrangement for lunch for people who came in early morning at 6, 7, 8, 9, 10, 11, 12 o'clock, because it was not fair on me to keep them starving. Hence, I couldn't account for the number of heads. So those people who couldn't have the lunch because of shortage of plates, I apologize. This was not the part of the original meeting. As far as the speakers and their credentials are concerned, most speakers, if you see in the list of fellows course, are genuine CTO operators, and they have the know-how of CTO. So please utilize these people and their knowledge, so that you can take home a lot of things for people who want to start a CTO program or who want to enhance the CTO program to the next level. Evening, by the end of the last session, we will have a breakout. Dr. Vijay Kumar from Triple M is going to take an IVAS basic session, which will be done in this room. And Dr. Ajit Pillai from JIPMER is going to show a video presentation on use of rotablation, how to use the rotablation in people who want to learn rotablation. And there is a wet heart model also there. That wet heart model, he will actually show how to do it. And that wet heart model will be there for next 1.5 days. So you people can go and actually use the wet heart model, and those people who want to get trained in rota, the actual Boston engineers and the proctors will be there with the wet heart model for you to use it. After the breakout sessions are over, we will have dinners behind at that particular place, and not the dinner on this side. This side dinner belongs to the other group. So our dinner will be outside. It's a good place, provided rain doesn't come. If rain comes, we can have trouble. Let's see. What more? We can fall short of place because I see a lot of people coming in today. Already 300 people are checking into the hotel today. So around 175 to 200 have already checked in. Another 100 are going to check in from now till evening. and there are 147 registrations from Mumbai, and another 75 to 100 are staying in other hotels. So if there are shortage of chairs, we will try to arrange some other 50 chairs sidewise. So I think with this, I think I've covered everything what I wanted to say for this fellows course. Tomorrow we will have the whole area for ourselves. There is a grand ballroom on that side. There will be an exhibition center outside. There will be rooms on this side which will have a couple of, both the rooms will have 4 industries conducting their simulator programs. So at the registration counter, you can register yourself for simulator programs. One will be for, mine is ringing. So one will be by the Spectranetics on the laser, use of laser in PCI. Then we'll have the ITOS system. These 2 will be in one room, ITOS system for CTO wire manipulations. I request you to register yourself because each slot will be for 15 minutes. So it is not fair that we walk in and and also when your slot is given for 15 minutes, please use that slot and leave it so that the next person can use it. Then the other room will have Boston and Terumo. Terumo will have the radial models. They have 3 radial models they will have. So this is as far as the simulators are concerned. Even Abbott will be bringing their, I should say St. Jude's now, Abbott is going to bring their OCT, and you can have a little go at the OCT also. We will have live programs tomorrow, which I will tell you tomorrow. So I think let's start the program. For the first session, my co-chair, Dr. P.K. Goyal, please take your chair and I will join you. And I welcome the first speaker, Dr. Ajit Pillai, who has been instrumental in actually designing the entire scientific program. So let me congratulate him for making a beautiful scientific program. Ajit.
Very good afternoon to all the delegates, fellows especially, and all the experienced operators as well. So this is actually a lucid overview of CTO PCI. So just let's all get the ball rolling. So when to take up and when not to. Okay, there is some overlap with the subsequent lecture to follow the system setup, but I will come to that because it's justifiable that in addition to the literature, we also know how to take a case actually. So patient selection is also important, but case selection is even more important, right? Okay, so the slide here is not moving in my system. It's not moving here. Get a pointer for me. So, slide transition. Okay, so we all want to do CTO PCI, that's why we are all here. But then again, we should go back. It's being jumbled up. Okay, so
I request you all to take the chairs in the center also, so
do
that
we
more
really
people
have
can be
data
accommodated.
which support us to do CTO PCI? The answer is no, right? So we have real dearth of randomized control trials. So if you look for evidence to support our CTO PCI, it's not there. So then why we want to do CTO PCI? The 2 trials in 2017 published, not published actually. Decision CTO presented in ACC, Euro CTO trial just presented last month by Gernard Wormer in the Euro PCR. Now, what do they tell us? Decision CTO, we'll spend some time with this because it's an Asian trial. 19 centers, 1 center is from India. PI is SJ Park from Asan. He himself is not a CTO operator. CTO PCI was compared with optimal medical therapy. You have lots of data comparing CTO PCI versus patients who have failed CTO PCI. So success versus failure, if you see a lot of data is there. All a single trial, multi-center, prospective, large numbers, more than 1,000, 2,000 patients are there. Even Japanese trials, if you see large number of patients are included, but none of them are randomized control trial comparing CTO PCIs vis-a-vis medical therapy. Okay, in this trial, 400 patients, the investigators have really struggled to garner the numbers. The study was chopped prematurely for want of enough numbers. Finally, they were able to muster around 400 patients in both the arms. De novo CT were located in a proximal to mid-epicardial coronary. with a reference diameter of more than 2.5 millimeters. So it's a real workhorse case for all CTO operators. Proximal LAD CTO, proximal RCS CTO, proximal circumflex CTO, vessel is big, more than 2.5, okay, justifiably included. But they excluded distal CTO, they excluded CTO in all the 3 vessels, and they also excluded CTO in both the vessels, like 2 CTOs, proximal LAD CTO, proximal RCS CTO excluded. Of course, left main was an exclusion. Instantration was excluded, post-cabbage was excluded. So this is more or less a representative of the cases which we do day in and day out. Next slide, please. Revascularization of all significant non-CTOs vessel lesions were all recommended, strongly recommended. Most of our patients do have a single vessel CTO, say for example RCS CTO, and then have a LAD 80 to 90% proximal stenosis. Such patients were strongly being subjected to stenting of the non-CTO lesion, even in the OMT group. So that is fairly representative of what we are dealing with day in and day out. Dual antiplatelet was continued for 12 months, and then the data was analyzed for 3 years. Absolutely no difference. CTO-PC is as good as optimal medical therapy. The trial design was non-inferiority. OMT was non-inferior to CTO-PCI. Okay? This is in terms of MACE, major cardiac events, MI, death, stroke. Now, benefit of CTO-PCI is in question because with the dearth of randomized controlled trials. Decision CTO, as we discussed, is a negative because it's non-inferior. OMT is non-inferior to our CTO-PCI. Then there is last year there is a good publication from the US Veterans Affairs. It was octogenarians who have been prospectively following CTO-PCI. This is similar to the data which has come up from Japan a few years back. People who undergo CTO-PCI tolerate future MIs much better. If somebody is doing a very large number of primary PCI, we know that more than 50% of cardiogenic shock in AMI are due to multivessel disease, and contralateral vessel is CTO. So clearly we know that there is a tangible benefit in patients who undergo CTO-PCI and then you sustain an MI in the future. So this was nicely pointed out by the US Veteran Affairs study. Less incidence of cardiogenic shock. That's what we want. All of our patients in AMI die because of, despite opening the vessels, we found that more than 50% die in cardiogenic shock, real cardiogenic shock, despite all your LV support systems. EuroCTO, just a word about that, that was presented by Gennard Wormer last month in EuroPCR. They have almost similar design to decision CTO, randomized controlled trial, slight difference. The endpoint of anginal class was slightly put as a different thing. So they could only prove that there is an improvement in the anginal class in patients with CTO-PCI. None of them have difference in the MACE. So again, there is no mortality benefit, no benefit in MI or TLR. So here, clearly we know that CTO-PCI only improves anginal class. Now, as I told you, a lot of data, prospective data, control trial data, which clearly tell us that CTO-PCI is offering benefit. Yes, it does offer benefit. We'll come to that. For us, actually, you should look for registry data. We are not going to get randomized controlled trials because the population is so heterogeneous. And also you should remember that there are very few skilled CTO operators. It's not everybody's game. That's number one. Number two, if you really want to look at the complications, nobody talks about complications of CTO-PCI. Nobody talks about the ischemia, peri-procedure ischemia in CTO-PCI. So these are some of the elements which clearly undermine the benefit of CTO-PCI in larger trials. So RCTs are not going to come even in future. Now, the bottom line is relief of angina. Patients who you have a proximal LAD CTO, patient has significant angina, you clearly improve angina by opening the vessel. That's very clear. Patients who have large perfusion defects, silent ischemia, please do, it will improve long-standing approval. LV function improvement is no longer a myth. We have clear data shows that patients who have occluded vessel, LV dysfunction, viability present, clearly improvement in the LV function is present. Future MI, clearly data is favoring us. Future MI, there is clearly a tangible benefit with CTO-PCI. But you should always remember procedure risk to be weighed. Now, so patient selection is very crucial. Case selection is even more crucial. So when to take up? Patient selection. So generally we know, all of us doing PCI, we know what are the contraindications for CTO-PCI, PCI as such. So that is applicable for CTO-PCI as well. AMI, you don't end up opening a CTO in an AMI setup. Preferably you wait for 3 months. That's the norm. Renal failure. Now we are able to do patients with renal failure, even with moderate to severe chronic renal disease with GFR up to 25 to 30 because we use IVUS. So that significantly curtails your contrast usage. Patients with disturbed hemodynamics, high non-cardiac morbidity, bleeding risk, intolerance to diabetes, severe LV dysfunction, cardiorenal syndromes. So here is a procedure which is going to last longer. You need a calm patient, you need a stable patient for this procedure. So all the deterrents of this particular patient environment is a relative contraindication for taking up CTO PCI. There are some other issues which are not strictly contraindications, but you have to be really cautious. Severe LV dysfunctions, patient may require LV support systems. You may require anesthetic support because halfway through the patient procedure, patient may crash. End-stage renal disease, I already told. Renal failure, you should remember that more or less, if you do IVUS or CT, more or less calcified vessels, so more problems with crossing subintimal course as well as high sense of perforation. Very frail patients, uncooperative patients, patients with poor pain threshold, all are actually a risk which you should take on before you take up the patient. You should have enough support system, support staff, support medical in terms of anesthetist, critical care support. Now, case selection, again, it's very important. So we talked about patient selection. What about case selection? It's important. We clearly know that all the trials, if you see, a failed CTO patient will do extremely bad. They will come back with angina, they will persist with LV dysfunction, they will have high risk of MI and they die. So before you take up a patient with CTO, make sure that your success rates are very high. To the tune of 90%. If you don't offer, or if you don't believe yourself can open the CTO, you have to be really crucial in deciding whether you are really going to take at the patient. So failed CTO PCI is a very bad omen for the patient. So patient selection is very important, where angioanatomy understanding, inventory, as well as skill set forms a major play. Now, how will you select a patient for CTO PCI? Now, understanding the angioanatomy is extremely important. Please make sure you sit in the angio suite without any disturbance. Spend 15 to 20 minutes understanding the angiogram. That is extremely crucial. If you have CT scan data, you are in a very luxurious position. But most of us work where we don't have enough radiology or CT support still. So I think still for us, actually angio understanding is the most important thing. Perform dual injections, understand each and everything, both for antegrade as well as retrograde. This is very important. Length of the CTO, angulation of the vessel, distal vessels, calcification present or not, tortuosity, origin of the coronary artery from the aortic root, what guide catheter you are going to use. So each and everything is important. Because this is a procedure which is done on a stable patient, you have enough time in pre-planning. Always worry about ischemia. Ischemia is there for all CTO PCI. You are actually causing ischemia. Nobody talks about it in the trial, nobody talks about it in the forum. Never people talk about CTOPs always cause some ischemia to existing vessels. You have a middle lady CTO, you try to get in, you enter subintima, you dissect it, you ultimately end up losing a septal or diagonal, you make a re-entry, whatever it is. So you cause ischemia. The only issue is whether it's an ischemia is a major ischemia or minor ischemia. So how to prevent it? Understand very clearly your anatomy very well. You have a plan A, plan B and plan C. Very clear. Pre-planning is halfway job done. Antegrade, you use larger guide catheters compared to a conventional PCI. You use multiple wires, anchor systems, so long procedure time. Subintimal passage is very common. So you end up causing a large hematoma. Perforation is worse. And you end up using more aorta as well as tonus. So channel passage creation is more injurious to the heart. You create more vessel stretching and twisting. What about retrograde? Donor vessel is always at risk. That is very clear. Even in the best of the hands, you always can damage the donor vessel. Collateral tracking is always ischemic. You are actually knocking off or occluding the collateral artery, which is supplying a viable myocardium. So definitely there is ischemia. Heart is being stretched. If you are using a combined anti-retrograde or retrograde technique, you are actually, heart is being twisted like a towel between your anti as well as retrograde gears. So that itself is enough to cause ischemia and stretch. As we know that when you create anti-retrograde connection, most of the patients experience pain. They become little distressed. That's true. That is because the heart is being twisted. The pain is not only ischemia. Pain is because of vessel stretching of the vasa nervosum. Collateral injury again is more important. So contraindication specific to CTO, never attempt to retrograde through a critical donor artery disease. If you have a donor artery disease, fix it before you take a retrograde route. Collateral surfing where single perfusing coronary artery is extremely dangerous. Never do that. Trans-lima to LAD, it's extremely dangerous. We have done cases, some of the cases we have real disasters because you never look at above, you always look at the heart. So you end up dissecting the lima, whatever not. So lima tracking, retrograde, extremely dangerous. You have to be very careful. I'm not telling that you should not do, but be extremely careful with that. So there is some learning curve with that. Antegrade approach, understand the proximal cap, length, angulation of the proximal cap, use of imaging to understand. Here is the importance of imaging. Again, stress, you should build up your IVUS imaging skills if you want to really succeed in CTO PCI. It's very crucial. Most of my CTO PCI end up using less than 150 to 200 ml because my knowledge in IVUS. IVUS is a must to learn. CT scan is a luxury here in Indian setup, but if you have it, please use it. But it only tells us the calcium. But when you, in terms of wire maneuverability or wire remaneuverability into the true lumen, IVUS is extremely important. Presence of the calcium in CTO, it's very important to know whether this is calcified or not. Sometimes angio may not pick up, IVUS will bring in. CT is even more sensitive to bring up, whether it's a half moon or full moon. If you have a full moon calcium, you forget antegrade. It's more or less, it's becoming difficult, right? Distal cap is again important. We'll come to that. Now, length of the vessel is very important. Longer length means, obviously, it's a longer procedure, needs multiple guide wires as well as increased chance for going subintimal. A small tip. If you have CTO segment of more than 25 to 30 millimeter with unclear distal end, please don't use Gaia wires. Okay, especially the present Gaia wires, not the Gaia next. So that's the tip. So if you have a very long CTO, you invariably don't use a Gaia wire. I take another 2 minutes, just finishing. Angulation is extremely important. Angulation of the vessel, proximal angulation of the vessel. You need to take up anchor systems for support. You need to take sometimes guideliner for support. A stiff wire cannot take the bend. Very important. Hence, with an extra workhorse wire, hydro wire, you use and then you swap. Tip again, angulator segment, never take a wire of more than 3 gram tip wide. You take a workhorse wire, cross the angulation, and then you swap. Imaging, pre-op CT I've already explained. IVUS is very useful. Knowing angio architecture and course of the vessel is key to success. Dual injection, let me please explain to you, please use dual injections. Never, always take double access in CTO, even however simple the CTO is. It will remarkably improve your success rates. Don't try to puncture the contralateral femoral once you start getting trouble into the antegrade. Please take double injections. It's the biggest mistake we can make. You will burn your finger someday. Okay? Always take dual injections. Spend 15 minutes, at least multiple views. Perform anti and retro injections in serial synchrony. Repeat views till 4 points are clearly understood. What are the 4 points we should know? Proximal cap, length, distal cap, and interventional collaterals. These are very important. Do I need to do a dual injection in an antegrade case? I am not capable of a retrograde technique. So should I do that? The answer is a big yes. You should always perform a dual injection, irrespective of your approach. So this is an RCS CTO. Quite difficult it seems because it's a branch point guide is not very good. There is no good branching point for anchoring and all. Now let's see what is being done when I took a reverse dual injection. See that it helps us a lot because it tells me that it's a very short. Only thing it had a little bit more support antegradally, I can just pass in. So that's the utility of a dual injection. Only the RC should helps in understanding the LAD CTO anatomy in this case. Similarly, RCS CTO, we find that there is multiple CTOs and we have a ruptured plaque in the LAD ostium. Retrograde, understanding collateral anatomy is important. Selective collateral imaging is important. Understanding the behavior of wires, ability to connect antegrade wires. So come back to our thing. Symptom control.
Pillai, if you could wind it up, please.
Yeah, please. I'll just finish.
Because all these things will be covered in
detail.
Yeah, in detail. Huh? Please.
Thank you. So I'll just come back to the last few slides.
Yeah, if you could show the last slides.
Okay. Slides. Yeah. We should always remember that. I think we'll come back to this. So I'll come this. So rule of 3 was relevant earlier, but now it's not. Probably we take about 3 hours a limit, but radiation is more important. 3 gray is a limit we always follow, but 10 gray you always stop. So 10 gray is a limit. Contrast volume now it's not a concern with IOS users. So to conclude, CTO PCI is the next level in PCI. Please use dual injections. Know the anatomy very well before you take up the PCI. When there is some problem, please take the judicious call to stop and then come again. Thank you. Sorry for exceeding the time.
Yes, I would like to thank the organizers and directors to invite me to give this talk. While my talk is loading up, it's very important. Obviously, I won't be talking about any procedural techniques or any glamorous stuff, but just about basic things, what we do commonly, bread and butter stuff in the cath lab if you want to do CTO PCI. And those things are very important, the planning, programming, how you do the procedure. Can I have my presentation, please? I'm really pleased to see so much interest in CTO PCI, which is really tells you the success of these IJCTO meetings going on for a few years, and the success is increasing and more people are taking up complex skills. Do you want me to bring my laptop? Right, so how to set up a CTO program? Obviously, there are several aspects to it. I won't be talking much detail about why you do CTO PCI. You all have to remember that CTO is different than a native vessel angioplasty. It's a complete occlusion of the coronary artery. Substrate is different. You have to use different procedures, different wires, different equipment to do the procedure, and procedure usually take a longer time. And also you have to think about the patient. There are risks involved to the patient, so you look for the safety of the patient. Then obviously your supporting staff is very important who will be helping you in the procedure. You have to look at the safety of the procedure, awareness of the procedure, and then reducing radiation is the more important thing, both for the patient, for the staff, and for the operator, and obviously monitoring the procedure during so that there is no complications. Now, from the operator point of view, you have to be obviously, operator have to be patient. It's not a primary PCI situation or anything urgent. Operator safety is equally important, and obviously should be aware of risk of complication. Now, what is the essential components of a CTO program if you're planning to start? You should address the clinical needs required in your circumstances. Education is more important. Program, start slowly, build steadily, do not overhype, review your failures and successes, take up simple cases first. Operator should be passionate about CTO, believer in CTO. All this randomized data which have been published recently is putting off some patients, but angioplasty in chronic stable angina setting is never going to improve the mortality or the MACE outcome. It's only to limit the angina symptom benefit and improving the LV function. Then obviously operator has to learn and continue to learn new skills like these meetings, attend hybrid techniques, engage with expert colleagues, and manage complications well to get a good outcome for the procedure. So when will you do the CTO PCI? These are some of the things I will want to skip. My earlier presenter has already covered them. Now the patients who will benefit from CTO PCI, in my mind, is a single vessel CTO with refractory angina, previous bypass graft and failure of the bypass graft, or coronary artery bypass graft turned down. These are some of the cases where you can take on as a CTO PCI and there is no conflict with the surgery and there are prognostic benefit in these cases. Now, what other people like, obviously the doctor or operator who's doing the CTO case. The other people are also important, like administrative, secretarial staff. Things should be planned ahead of time. Avoid messing up with the schedule. You don't want to put 2 or 3 CTO in between your acute coronary or a hot lab list. That will take off all the primary PCI waiting outside and you're doing CTO inside. So you should have a arrangement where you've got 2 labs, hot lab or CTO lab staff, when the patients, and the staff should patient's interest top of the concern. And when you care about staff as well, encourage their contribution, protect their health as well. Now, I can talk about several things. The important thing is the inventory. You should have all these guide wires, different guide wires for different lab. You can see the list of these. You should have some workhorse wires, then soft polymer jacketed wires like Pilot 50, Fielder FC, tapered soft wires, tapered stiff wires, and obviously Confianza, Conquest Pro, Gaia series of wire. And also you should be able to use rotablator, intravascular ultrasound, guideliners, a range of different balloons, small balloons, large balloon stents. So you need to have all these equipment available as well. There's no good doing a CTO and then half of the case you have done and you ask for something which is not available. Then obviously microcatheters are very important. You should be aware of microcatheters, corsairs, fine cross, they should be available. Snare if you are involved in retrograde procedures, long sheaths, 8 French guide catheters, and Tornus OCT cross-pause stingray system, which is coming up depending on what kind of procedure you want to do. Now, in terms of patient preparation, it is very important. I'm just talking to you all from my contacts. A lot of emphasis goes on these things. I would say to avoid ad hoc CTO PCI. You've done somebody's angiogram, find a CTO, start. That is the problem area. It usually takes 15-20 minutes to assess the angiogram to find out the strategy. Obviously, consent patient as different like a CTO, depending on what your results are or what the registry in your country says about the mortality, MACE events. It's no good saying it will be safe, nothing will happen, and we do a lot of PCIs, and this is like another PCI. So you have to be realistic. Fluid hydration should begin early as possible. Now, preparing the patient, obviously, the different approaches. You should determine the strategy beforehand. Most of the time, you have to have bilateral approach, bifemoral, biradial, femoral radial, depending on your expertise. Intravascular IV cannula should be in place to check ACTs regularly. Pre-medicate your patient. And contrast dye allergy should be checked beforehand because patient will be having contrast for a long time. Answer any questions to the patient and discuss with the patient what you're going to do. Now, other thing is about the staff and admin, his CTO days versus morning CTO cases. In my hospital, I usually do a CTO case every other week, whole day, and then my lab is only do the CTO cases, and other lab is doing the acute coronary or other cases, so that you've got your time for your case, and this procedure might take 2 to 3 hours. Explain procedure to the staff. And obviously avoid authority gradient. This is one of the things that I know everything, you don't know anything. Staff should be encouraged to speak up. Is this the normal what you do? And obviously there should be equal weightage given to everybody. Use protocols. ACT should be checked very regularly. We say 20 minutes, every 20 minutes in retrograde cases, maybe every 30 minutes in antegrade procedure. If you don't cooperate, maybe the staff can turn the fluoro off because you have to cooperate. Sometimes, obviously, there is very difficult to do these kinds of things, but in my hospital, if you have 30 minutes, you have to check the ACT because you're putting the patient at risk. Maybe your procedure will be successful, but you don't want a dead patient. Be reminded of radiation every 2 grays so that you know how you are progressing. Be reminded of the contrast volume. This will be informed to you by your other staff. Use of radiation protection devices. And obviously, best way to protect yourself and your staff is to reduce radiation to your patient. There's no good protecting yourself and not caring about patient. So you try to use low frame rate, 7.5 frames per second. We normally use for fluoro when we do these procedures. Now, controlling this thing, you can put a catheter in the patient. This is the last thing you want. You are in the halfway during the procedure. Patient wants to go to empty his bladder and the blood pressure goes up, complication risk increases. So use catheter, diaper, whatever you want to use in your lab. Have generous sedation for the patient. Maybe some places give light general anesthesia. Equipment should be kept very, very easy to find. You don't want your technician or your paramedical staff running out every time you ask for something, or he's never heard of those things. So you try to keep your staff in the room. They might be needed. CTO cart is a good phenomenon. There are various commercial carts available. This is one of the carts in my hospital, which is available commercially. You can put all your CTO related stuff, including complication, covered stent, tornus, etc., in this trolley, and that will allow you to facilitate things, most of the wires and things, and then the stent and things wherever you keep. The stents is the last thing you will require, but the balloons, wires, macro catheters should be kept at the easy reach, and you know where they are and you know how to use them. And be relaxed in the lab. This is not a STEMI situation. This is not like you have to finish case in 5-10 minutes and you have to go 20 more cases to do after this case. So that's why you should have a CTO half day or plan CTO properly. The most common cause I have seen in some surrounding is doing an ad hoc CTO or trying to do CTO very quickly, not appreciating that it is going to be complex, just doing it with single injection. Those are the kinds of things you can easily avoid, and everybody who's a dedicated CTO operator can increase their success rate by 5 to 10% by following these simple things. Now use systematic approach. You will be using bilateral angiogram, 2 axes. So you have to talk to your support staff that you will be using 2 axes here. Now you need to know which axis is antegrade, which axis is retrograde. Some people go with color coordination. The waveform should be different. You can have the same waveform. Color coding is good, and then you would know which monitor, whether the pressure is damping or not. And this is how you can reduce complication. Now wire management, you will be using loads of wires. You will use one wire, then you take other wire escalation, wire de-escalation. So keep all wires on the table and advise your supporting staff not to put them in the bowl, and then you are searching your head which wire is which. Obviously some experienced operators might tell by looking at the back end of the wire, but sometimes it's not that easy. There's several wires available, so you should keep wires into the tubes back, put some stickers, keep wires safe, so that supporting staff will be able to give you that wire back, because you will be using some wires, then taking another wires, and then you might need other wires. And the people who do these procedures, like you are into knuckle wiring, antegrade dissection, re-entry, don't throw away your mangled plastic or broken wires. They might be useful later in the procedure, so just keep them somewhere safely. Now coming on to radiation exposure is very important in these cases. People might not take it very seriously. You should take it very seriously. There is some data coming up. Higher the radiation exposure to the operator, there could be major consequences. It all gets accumulated. So you have to start taking stock very early in your career. The procedures are lengthy, change angles frequently, so you have to involve your radiographer. He should know what he is doing, where the probes are, where your lead protection is. I visit several cath labs in India, and sometimes I find the lead sheet, which is a protector sheet, is not like a barrier between you and the patient, is stored away somewhere back into the lab that you don't want to use it. So you should try to use, at least for CTO cases. Radiation pads could be used. There are some commercial pads available, right? Red pad available, which has shown 80% reduction of scattering of radiation to the operator. Increase distance from fluoro tube as much as possible. Decrease distance from X-ray diffractor. Collimate your image. These are the things. Now, your radiographer is a very experienced person. Take his help. He would know, and keep changing the angles if you are trying to stay in one angle for a long time. Now, obviously, as these procedures are not simple, sometimes you can have complications. So you should have all these drugs available, like inotropes you should have available. You should not be running around when you get problem like bradycardia or hypotension. Have some kind of thrombin, microbeads or coils, whatever you use for septal channel perforation or minor perforation, so have them available. I usually keep them in the bottom drawer of my CTO cart. Coils, we use coils. If you are easy using beads, you can use them. And have pericardiocentesis kit ready, and know how to use it and know where it is placed, because this is the last thing you want, your successful procedure, patient tamponading. So you should need to have all these prepared. For the preparation is everything. Obviously, recovering a CTO patient is one definitely an area where your support staff is very important. You need to have designated areas where it goes, how the sheath will be managed, how the ACT will be managed. Does the patient need protamine? If there's a minor perforation, procedure went successfully, try to give protamine, to reverse protamine to prevent any long-term problems. And obviously sometimes in the middle of the night or something after the procedure, if something goes wrong, contact person who could commit. And if some people are, and if the competent staff is on site who can take care of and identify the complication and can do the pericardiocentesis, there is no good leaving a CTO patient, complex patient, which could be not approached pretty quickly. Now coming on to the operator as well. Now obviously the support staff is important, but operator is also important. So you need to know your limits, and how this is a data from EuroCTO club, level 1 CTO operator, level 2, level 3. What this means is, as you increase your experience in non-CTO angioplasty, then you increase your experience in CTO angioplasty, you increase your success rate and you reduce your complication. So people suggest, if you are an early beginner, you should try to take low risk cases like IJCTO 1 or 2 cases. Your success rate will be high, because you don't want to have many failures early in your career. That as your experience accumulates, you can start taking complex cases. And this is one of the algorithms if you've done several. So it's not that you wanted to learn CTO cases first. You need to be well proficient in non-CTO angioplasty, learn to identify complication, treat complication, then you take on CTO cases, and that is an easy, good way to do it. Now, how you learn these skill sets. There are a variety of different things in the audience. Some experienced operator, myself, we have gone through different things. There's a jumbled way of learning different techniques and getting CTO mastery, and there's a structured way as well. For the new operators who are coming up now, there are structured ways available. Maybe 10 years back, there was no structured way available. Everybody learned from each other, like proctoring, visiting other centers. But now there are structured ways available, how you learn these procedures, attending these meetings and complex meetings. Now, these are some of the building blocks people suggest. You can start with basic reading of an angiogram, then develop antegrade skill, then develop retrograde skill, then go to hybrid kind of skills where you use antegrade dissection re-entry or retrograde or more complex strategies. Slowly build up, and then you can build up your success rate high. Now, this is one of the pitfall which people say, oh, we started doing CTO, we did 5, it didn't work for us. So this is the problem. Over enthusiasm at the early stage might be a problem. Don't be over enthusiastic. Choose your case properly. Avoid highly complex cases early on. Systematically build your skill set. Rome was not built in a day. The operator who you see, experienced operator doing retrograde cases, they've been doing these cases for last 10, 15 years. Then they've got to this point. You can't start doing retrograde and everything ADR. So learn your antegrade skills very well. This is the data from NCDR registry from US, where they've shown that experienced operator and successful operators increase the success rate, as you can see here, and reduce the MACE rate. That is what it means, is that if you build up your experience, you will increase your success rate and you reduce your MACE rate as well. And there are a lot of benefits. Some people think, why do I do CTO? I do a lot of other stuff, but you become overall a better interventional cardiologist when you do CTO PCI. You learn recognizing complication, increase the PCI volume, and these are some of the benefits to the operators. And there are benefits to the hospital as well. You attract more referrals. Your hospital will become well known. You can increase the volume of your cases done in your hospital, increases your reputation. So in summary, ladies and gentlemen, building a CTO program is based on best practice. It should be patient-centered approach to patients. CTO PCI takes more effort and persistence and a challenge in mindset regarding speed, devices, and switching. Speed is not everything here. Via the hybrid algorithm, operators should be humble, collaborative, and willing to adopt new approaches. Will find CTO space and community highly rewarding. And CTO days work best. Cath lab preparation and education is very important. Avoid authority gradient. Just think that everybody is equally important. Use some protocols, like what protocols you're going to use in the lab. CTO cart is very useful, and protect your patient and staff and yourself as well from radiation. So I'll stop here.
Thank you for being on time. We'll move on to the next speaker, my co-chair, Professor Goyal from SGPGA Lucknow.
Okay, at the outset, I would like to welcome all of you to this meeting. And I think with this full house, I think I should congratulate Dr. Ganesh for a fantastic meeting and next 3 days to come. So, you see, CTO, how to perform a comprehensive angioanalysis before a CTO intervention. So what is the first thing that comes to your mind? Before you could perform a good angioanalysis, one should have a good angiogram worth the same first. So if the angiogram has not been done worth, as just pointed out by Dr. Ganesh, that the guy who's doing the angiogram, he is not a CT operator. You see what you know. So the common misses are very few shots, and I think you will agree with me, there are angiograms, very few shots, 2 right injections, 2 left injections. That's the end of the day. I don't think that will tell us anything. Poor views, either all RAO types, all LAO types, and you don't have enough information. Poor non-selective injections. You see, he's just hooked the artery somehow, and an injection is there, and there is hardly any interpretable information. Then how can you do it? Field of viewing is so small that the distal artery, which is to be seen, is not seen because it's filling from the opposite vessel, on the opposite side, and you have not looked for that. You have not either panned for that, or the field is very small, or the field is so big that you have free air in the entire angiogram. A basic principle of angiogram, you cannot have air in the space, because when you have air and body tissues together, there's so much of contrast that your picture quality goes down, so you can't interpret. And when you have such a big field of view, your arteries are like threads, and you cannot interpret. You want good size. So few basic angiographic principles. I am just wanting to tell you, coronaries envelop the heart in 3 dimensions, but are visualized in 2D. You all agree? So visualize always the heart behind the coronaries. So whenever the anatomy is wrong, something is missing, you will always realize that this will help you. And get the concept of distance. 2 points which are looking very close together on an angiogram could be miles apart on the other view. Like me and that point. If I see from here, both at same point, but if I see from here, he is there and I am here. So this is very important. That's the principle of orthogonal viewing. A good angiographic technique involves, in every cine run, have an initial dry run, which will show you some calcium, hanging contrast, etc. without the injection. Contrast flow rate should be commensurate with the normal flows of that chamber or the vessel concerned, because you need to fill the entire vessel with so-called radio-opaque substance, that is contrast, which is free of blood, which is radiolucent. Then only you will be able to see it. Otherwise, you can't see it, and several times it is this underfilling that creates a problem. Filming must last long enough for the contrast to reach the distal blocked vessel antegradally or through collaterals, because it is the distal vessel that is more important for us in all CTO interventions. So we have to see the distal vessel, and distal vessel is always seen. If it is not seen really, then that patient cannot be done or should not be done. That's all dead area. If the area is live, it will always be seen. Follow the dye chamber to chamber or proximal to distal. Just a few more tips. Always attempt to look for the opposite blocked vessel in any native injection, as I just said. Run the acquisition long enough. You may be surprised to note that occlusions that seem long may not actually be so, and almost the entire length of the vessel can be seen from a contralateral injection, provided you attempt to see it. This is an indirect marker of the length of the occlusion, and you may not really need a CT, unlike conventionally you think that only a CT can tell you the length of it. So how angiographic technique makes a difference? I'll just show you a few examples. Now this is a diagnostic angiogram. Diagnostic catheters have thinner calibers, and sometimes the resident has done the injection and it is not really. So if you see this injection, what do you feel? Well, the LED is blocked, the circumflex is blocked, everything, you get an impression the patient for surgery. Yeah, this is not possible. And then the same through a guiding catheter, you see there is a delayed filling in the LED and also of the circumflex. So both have a tiny channel through, and this is what will make you the success, and you can easily complete this procedure. So completed. Another patient, now this patient actually in fact was a live case which we were trying to do with an international operator. And you see the right injection, and you don't see much in the distal vessel. Well, that means it will fill through collaterals. So the left injection also, oops. So the left injection also only shows the distal RCA very distally. It shows very distally, so seems like a very long occlusion and very difficult to do. But then when you do a contralateral injection, this is not the contralateral, when you do a guiding catheter injection, you see how from the RV branch, the entire mid segment of the RCA is filling, and we know that the occlusion is small, and we will be able to do it without much difficulty, and that's what was done. The importance of contralateral injection. This is only way to see the see and understand the distal vessel beyond the occlusion if it is not filling through ipsilateral or bridging collaterals. And this is always a must before you can proceed for CTO, high-end CTO dedicated wires. So you have to put these wires only under vision of the distal vessel. So you have to make all effort to see the distal vessel. And at times there are multiple sources of collaterals. So you have both ipsilateral and contralateral, and you have to see all that, then only you will be able to make a decision. Now this is a case I'm just showing you as a multiple collateral source. Now you see LED, you see it proximally, and then you see it distally, but it is only through contralateral injection that the mid part is seen. It's only in the contralateral injection that the mid part is seen. So that's multiple sources of collateral. So you should understand that, and when you will link the two, you will know that the occlusion is small, and you can easily do it. So angiographic interpretation actually makes a very important role in all CTO procedures. This is another case. You see, RCA is occluded, distal is not seen, but it's only when you do the contralateral injection in the third one, and when you link the two, you find that the segment is very small and you can do it. Now, this is another example of multiple collateral sources. So I think I'll just skip that. Again, there is a mid-LED part which is filling through the RCA, and the ipsilateral collateral only fills the distal LED. So all these things have to be interpreted in your angiogram. So for which you need to see these, so which the person has to show this first. A few more angiographic analysis principles. Frame by frame analysis. This is very important. Understand the angiogram as a collection of 60 to 70 images rather than one shot. So if you have 7 diagnostic angios, you have about 500 images to interpret in your brain computer, and not just 6 pictures. And inch by inch analysis. Inch by inch you have to trace the vessel just like you inch a murmur. So because several times there will be an end-on segment or a tortuous segment where there will be a small little hairpin type of occlusion, and you will be missing it. Differentiate between antegrade filling versus retrograde filling. This sometimes is you can miss it. And frame by frame analysis will only give you the answer to that. Now this I am showing you a case, LED occlusion. I am sure seeing this angiogram you would certainly feel that this is filling antegradely. But when you do a frame by frame analysis, if you see this, I have stopped at frame 30, followed by 34, and then 38, and then 57. And you see the sequence of filling. The first part, only the septal is filled. The LED has not come. Then distal part of the septal starts coming. Then proximal part of the septal and the LED starts coming, and then more LED fills. And by this you know that this is retrograde filling. It is not antegrade. So this needed a strong wire like concurrence, and then we could complete it. This is another case. This looks like a total occlusion. It seems that there is nothing beyond. The filling must be all retrograde. You have filling from the left of the distal right. But now when you start seeing it frame by frame, total, next series of frames, you see something coming here. Now this, maybe you're not able to decide it here, but which is better seen on a real running angio. And then even distal, which tells you this sequence of flow is antegrade. And this could be crossed with a XT. And you could complete it. Concept of parallax. Movement in line with the artery versus independent of the artery can differentiate between wire is in the vessel, or it is in a side branch which is moving independent of the vessel, or extravasculars. And this is a thing which you have to answer several times while doing the procedure. So understand this concept of parallax. Intraluminal versus subintimal distal wire location. Orthogonal viewing is very important and is confirmatory. You feel that the wire has gone almost, you're working in the areocranial view and you feel that your wire in the LED has just gone across the distal LED. But the moment you'll see a LAO view, you will know that it is miles away. So always have to have the bilateral viewing thing available and going on. Recanalized vessels, at times you feel that antegrade filling vessels is antegradely filling, but it is truly a CTO. And you sometimes see tortuous anatomies inside, and you feel it is antegrade flowing, but nothing will go. You will need very tough CTO wires to cross. This is what is truly a recanalized vessel, which is also a CTO. True antegrade filling versus bridging collaterals. Sometimes what happens, there is a bridging collateral, there is no antegrade flow, but there is a tiny twig which is dancing over the same area, and in some views, in one particular view, it is just falling in over the main artery. You have a feeling that it is flowing through. But when you see the opposite view, the orthogonal view, then that branch separates out and you find, oh, this was a bridging collateral or a branch, and it is not really the true segment. And lastly, for retrograde procedures, I think 2 important things to be judged. One is Disease in the donor artery, well, either it should not be there or you have to fix it. Second thing is the collateral patterns. So collateral patterns, well, there are standard collateral patterns. I will not go into the details of it. You can know about that, septal and epicardial. So they're standard patterns. What I want to highlight here is the understanding of these channels, collateral channels. You should understand how to get their tortuosity assessed. And this can be done by something called an amplitude diameter ratio. If the amplitude diameter ratio is high, then it's more tortuous. So sometimes channels look very straight, but they have small wavy character, and this wavy thing makes passage very, very difficult. Understand that. Now this, like it shows, this is an enlarged frame of the same thing. Looks straight, but you see this wavy thing will not let the wire go. It will get stuck. So this is at least moderate corkscrew collaterals. As against this looks tortuous to you here, but there is a twig down which is straight and it is following this track, and it is forming something called a B bump. This is very classical, and when you have this is very, very straight collateral, and this will immediately go. So just to understand that. Now this is another septal collateral. Now this is straight segment, absolutely straight. So when there is straight, then it will easily go. So that's a good collateral example. So with this, I think there is no end to understanding the angiogram, but I think what I would like to conclude and take home message, that a skillful performance and good interpretive acumen of moving angiographic images is the bottom line for a successful CTO procedure. You need the radiologist's eye and the cardiologist's mind. That's what I feel, and you will see what you know. If you don't know something, you will never see it. Thank you.
Professor Goyal, thank you for being on time. You actually saved 1.5 minutes for me. Dr. Duggal will be the next speaker.
Good afternoon. Now, what to know before we begin? The most crucial step is a good support of a catheter for doing a CTO. It is quite different from a non-CTO lesions where you do not require that good support. Now, for this, what is important is the access, the support sheets, and the selection of the catheters. Now, the two basic approaches, the radial and the femoral approach, by a default strategy, most of the operators use for CTOs the femoral approach, but more and more are going to the radial approach also. You have a bilateral femoral approach, you have one radial, one femoral, or bilateral radial. Now, the CTO PCI, the catheter support during CTO PCI begins with careful selection of appropriate guiding catheter. And why you want to have a careful selection? Because you need to have a coaxial alignment, and you need to have good catheters so that you can have good opacifications of the vessel, especially if you are seeing at the collateral vessels, allows delivery of hardware, equipments, IVUS, Torners, crosshairs, and further on, and you need good support during PCI. So it is based on the vascular access used, the coronary anatomy, the aortic anatomy, and the specific lesion characteristics. Now you have to enhance your support. This is different from a non-CTO PCI, so you have to use sheets. And long sheets, which I'll be coming, give better support. You have guide catheters of varying sizes, higher sizes give better support, and stiffness contributes for the same. Guiding catheter shape is very important, what guiding catheter to be used in what anatomy, guide catheter extensions, and anchoring support. And there are some newer support catheters. Now, long sheaths. This is, of course, a most underappreciated or estimated yet an important factor in providing support to the guide catheter. Now, it helps to improve support, improves ability to torque your catheter, especially if there is a peripheral vascular disease and tortuosity, you have iliac and femoral tortuosities. Standard sheath is varying from 6 to 23 centimeters. Here we have 45 centimeter, which almost reaches the diaphragm. Supposing you take a catheter which is 100 centimeter in length, and you have a sheath which is 45 centimeter, So you are providing a support almost 45% coverage of that catheter. Now, bilateral approach, femoral, if you do it, there is some risk of thrombus, and therefore you have to be careful when you are removing the catheters and you have to aspirate them. Now coming to the size. Now size increases support. As you know, French multiplied 3 into gives you the millimeters. Guide catheters have decreased in size because of better material, larger internal diameter without increasing outer diameter. Using small size guide catheter is intuitive and it decreases the vascular complication, and this has been amply shown in a study of more than 1,03,000 patients. Larger size is associated with more contrast, associated nephropathy, more bleeding, excess site complications, more post-operative blood transfusion, and more hospital maze and higher mortality. 7 French guiding catheter, you can use a Corsair, a crossboss, and a tapping balloon, whereas 8 French is required if you also need IVUS guidance. Meticulous technique is what very important to avoid complications. You can do a ultrasound guided puncture. You must go into the common femoral and removal and pressure techniques so that you avoid complication. Stiffer guide catheter give more support. Now, guide catheter shape depends on the location of the ostium, whether it's high, low, anterior, posterior, or it's anomalous, and the size of the aortic groove. Now, catheters now are very well classified, especially for CTO. They are classified as over-bent catheters or under-bent catheters. Now, over-bent catheters are what we normally use as VODA, Judkins, EBU, XB, Q-curve, whereas underbent is Amplats and multipurpose. Now, manipulation of underbent catheter is harder and can lead to aortic and coronary dissection. And this is important and vital for catheter manipulation. Now, coaxial alignment is that what permits transfer of forces needed to advance the device, the hardware safely. And aligning the catheter tip along the long axis of the artery is what we need to do. For an RCA, the optimal alignment is Amplatzer. Now, internal memory catheter, hockey stick. Judkins is used, but it is only for where you have proximal lesions. Inferior takeoff RCA, you use multipurpose, Judkins and Amplatzer. Large aortic grooves, again, Amplatzer and multipurpose. Now, shape is also very important, as I've said, and for left coronary, we use extra backup, XB, VODA catheter, especially for if you want to do a circumflex left VODA, geometrical left Amplatzer, and Judkins. And Judkin, as you see, mentioned in the last. These are the various shapes, you have all seen that. Now, what is active support and passive support? Now, in CTO, PCI, you should have a combination of both active and passive support. Now, if the catheter tip is soft, what is required for active support? For a passive support, you have a long tip catheters. Shape can be altered. For active, you can alter to accommodate the aortic root, whereas in the passive support, it rests on the aortic root on the opposite side of the aorta. Guide catheter size, active support decreases with larger guide catheters, whereas passive support increases with large size guiding catheters. Curves, more flexible primary curve for active support and stiffer for passive support. And the risk of aortic on coronary dissections are low with active support and higher with passive support. Now, guide wire extensions. Now, these are available which can enhance your support. There is the heart rail from the Thermo Corporation, that is mother and child, guide liners from Vascular Solutions, and Guidezilla from Boston. Now, they boost up their success rate as well as you taking material forward, but they can cause stent sharing if it is withdrawn, proximal vessel dissection, and loss of catheter tip. It has a definite role also today in retrograde, where you can decrease the travel of the retrograde guide wire if you have a guiding catheter extension which can be taken into the coronary artery. Now, this is what is the mother and child. It's got two EBOST, if you can see one, and the smaller catheter is inside, and you can take it over a coronary wire. This is the mother and child in an Amplatz catheter. You have this is a guide liner, and over the guide liner you have, inside the guide liner you have taken the balloon or a stent. Now, the guide liner is 20 centimeter extension connected to a rapid exchange push rod system and deliver the guideline over a in situ guide wire, then deliver the balloons or the stents. You have compatible with different sizes, 6, 7 or 8 French, and it is deep seating for added backup support, coaxial alignment, selective distal contrast, delivery and protected distal stent delivery. Now, care must be taken when you're doing is to avoid, when you're putting a second wire, you may entrap the wire or you may wrap around the, so this is very important. Delivering a guideline over a 014 wire will prevent wire wrapping and allow balloon and stent to enter the coronary collar freely. Now, there is active support. Active support is also achieved by anchoring. Now, anchoring is done in 4 important ways. One is side branch anchorage, which you always see. There is also a proximal anchorage technique. There is a power anchorage modification of proximal vessel anchoring technique, where you have taken a fine cross over a wire, and when you're trying to push, the fine cross comes out. So, you take a buddy wire, take another balloon and hold that fine cross or crosshair. So, this is what is power anchorage modification of proximal vessel anchoring technique, and of course, distal anchorage technique. There are certain new support catheters. One is a Prodigy support catheter, then is a center cross and the multi-cross. Now, this is what is anchor. You can see it in the side branch, which is, or you can do it in a diagonal or RV branch. This is an anchor with using Tornus. Now, this is a distal anchorage. Now here you see the stent was not going in, and you take a buddy wire and inflate a balloon. There was a previously deployed stent distally, and the stent easily tracks down and gives you the adequate support. Now, this is a Prodigy support catheter, which is a very soft material and can be inflated into the coronary, and over this you can take the wire. Now, this is center cross support catheters, not available yet. It's a single hole or multi-cross. You can have multiple wires in a different position you can select. With this, I'll complete this lecture, and thank you very much. And what you need, a combination of a good sheath, a good support catheter, anchor, and a MAC catheter or a heart rail. With multiple these 4 things, you can always reach where you need to go. Thank you.
Dugal, for the nice presentation. So now we have about 15 minutes for discussion.
Down to 7.5.
Whatever, we can have it for about 10 minutes. So if there are any issues, you see, we have basically just started the program with talks on how to set up the cath lab, how to interpret the angiogram, how to get access, and probably when to do, when not to do. So if there are any questions anyone has,
I request Dr. Duggal, Dr. Sudhir Rathod and Dr. Pillai to be in the room, because some of the questions need to be answered by them.
Yeah. Dr. Surya Prakash, yeah, please.
This is not questioning any of their lectures. One thing is regarding first Dr. Ajit Pillai, I feel the CTO PCI should be a caution. It should not be scary because the IJCTO series has done more than 700 so far with 0.1% mortality, to my knowledge. We are doing the registry now, so people should not be scared. The second thing is you have given an excellent view of the angiographic analysis. On the exit points are very important, are seen mostly in the caudal views. That's one thing. Second thing is the rotational angio is also very useful to assess this thing. Only 2 points.
Yeah, I think the first point is important about what he said about in Dr. Pillai's talk. You see, it's my opinion that when you do CTO procedures, maybe if a failed procedure, if done carefully, if you do a careful procedure and you know when to stop, I think there was something when to stop, that's very important, then probably you should not end up in a complication. That is, so it should not be scary. I think that I agree with Dr. Surya Prakash. It should not be scary, but it has to be done under a controlled setting. You should know when to stop, and then things are okay. If any other thoughts or yeah.
Just a brief comment. Obviously, it should not be scary, but we've got a lot of data to discuss with the patient. All the major registries, like if you see EuroCTO registry, Progress registry, Open CTO registry, Recharge registry, JCTO, the MACE rate is between 2 and 3%. Now, it sounds a little bit more, but mortality is 0.1 and 0.2. In all the trial, all the registries, mortality is 0.1 and 0.2. Stroke rate is 0.1 to 0, which is same as non-CTO PCI.
Yeah.
The MACE rate goes up because non-STEMIs are also calculated, like elevation of enzyme, side branch loss, and they contribute from 2 to 3%, which includes less of ST elevation MI, but more non-ST elevation MI, and about 1 to 2% in these trials of cardiac tamponade, but that doesn't reflect into mortality. That is like a morbidity. So you have to be cautious, prevent complication. Then it is the MACE rate are similar to non-CTO PCI in expert hands.
Actually, you should be very careful not to occlude a flowing artery. I think whenever we do a CTO PCI, the bottom line is you should not be occluding a flowing artery or a flowing branch. So if that care you can take, then probably you can maintain the complication rates other than your tamponade, which is usually manageable within the non-CTO PCI range.
Rajesh?
One question.
Oh.
Yeah.
In acute MI setting, during primary PCI, if we find other two vessels are CTO, what should be the approach?
I mean,
Acute MI, the other two vessels CTO. You see, I'll tell you, if that's I would like to open the acute MI vessel, the culprit vessel, and think about doing the CTOs at a second stage. Earlier, the concept was when all three vessels you cannot handle, then go for surgery. But today, things are a little different. Our hardwares are more congenial. We are doing more invasive, in the sense more complex procedures. And acute MI, which is producing cardiogenic shock, the patient would otherwise die. So, the moment you will stabilize the acute MI vessel, the patient will be stable. And then you can take your call. If you can do it, you do it, or else you send him to a center where CTO can be handled, or else you can even think of a hybrid procedure. You do a bypass for the CTO vessel, but acute MI, I think, if it's a big MI, if it's a big vessel, I would certainly. No, I don't think so. I don't think you will do at the same sitting. Someone said that in one of these 4 talks. It was.
I think
there.
Ajit very clearly said that.
Yeah.
My short comment to Dr.
Just,
Surya's comment. My intention was not to make the audience or the fellows scary about CTO PCI. I was just adding a word of caution as to this is not a regular PCI. You should take all the time in your world to prepare your case and then stop when a complication comes. In fact, I could not finish some of the slides I prepared. When there is a large subintimal space, you know that it's a subintimal space. There's a large dissection space proximally, or you always take time. And when we come back again after 6 or 8 weeks, we invariably be successful. So we have to be very cautious and judicious, and then hardware selection also is important. So like Dr. Datta was also pointing out with the hardware, planning is more important. As you take up more and more complex CTOs, planning is more important. If you have a clear-cut plan, then more than 50% of the job is done. Thank you.
Just to carry the discussion forward, since we are doing a lot of CTO PCIs, we're a little disheartened by this decision CTO trial. Can anybody offer an explanation why this outcomes were not superior, considering that we were revascularizing a viable myocardium in all CTO cases we've done so far?
If you look into the trial, decision CTO trial, or any other trial for stable angina, stable coronary artery disease, it all depends on the prognosis, or the symptom control depends on the ischemic burden. Now, it's not clear from decision CTO trial whether systematically what was the ischemic burden. If you do an artery which is not supplying maybe the significant amount of myocardium, people say it should supply at least 2 segments or more in 16 segment model of echocardiogram. When you do, you should attempt it. If it is supplying less than 2 segments, then there's no prognostic benefit. So the benefit will only be in the symptoms mainly, or in the cases of ST elevation MI and remote CTO, there is a prognostic benefit. So decision CTO, the MACE event did not include angina or symptom control. They include death, stroke, and urgent target lesion revascularization. That's why there was no difference between OMT, and it is same like COURAGE trial. There might be people who believe in COURAGE trial. This is like a decision CTO is a COURAGE trial of a CTO angioplasty, but you still do angioplasty for stable angina. So it all depends. Clinically, there should be large ischemic burden. Patient should be symptomatic with angina. In asymptomatic patient with CTO, they should have either shortness of breath or large area of the muscle which is viable by either stress echocardiogram, perfusion MRI. Then there's prognostic benefit.
If I can just add on to that question of yours, you see, you have to think, how will the mortality be less? Only if the mortality was high otherwise, then by doing the procedure, mortality could come down. Think about a patient. A CTO patient basically is a stable CAD patient by and large. So stable CAD, what is the annual mortality? It's about 2%. So how low will you bring 2%? I think that is my thought. How low will you bring? That is the reason mortality doesn't come down. But yes, angina relief is there. So like the Euro CTO showed, angina was better with a successful CTO versus non-successful. So I think it is largely related to the absolute mortality not being high even in medically treated, because they're all stable CAD patients, largely. CTO is stable CAD.
I would not agree they are stable patients. You know, you have a LED occlusion, a large viable myocardium with LV dysfunction.
No,
How can you
agreed.
say that's a stable patient?
No, stable means he's having chronic stable angina.
But his LV dysfunction might contribute to his mortality, which may be high.
Yeah, but that is what is being observed. I am just trying to give you an explanation as to why it may not happen, because if the absolute mortality is not that high. Why we get mortality reduction in ACS? Because the absolute mortality, 1 year mortality post ACS is in the tune of 10 to 11%. So which you can reduce by doing procedures. But this is not that high. I think this is a thing which is otherwise difficult to answer. So I think we can with this conclude this session and go to the next session.
We invite the next chairperson, Sir Dr. Surya Prakash Rao and Dr. PLN Kavardi from Hyderabad to come over and replace us and take the next session forward.